Hi, my name is Nicole Vigon, and my presentation is on the evaluation of joint dynamics during gait in children with hypermobile Ehlers-Danlos syndrome. The goal of my research is to evaluate the temporal spatial parameters, kinematics, and kinetics during gait in children with HEDS. Ehlers-Danlos syndrome is a disorder that affects connective tissues. Hypermobile Ehlers-Danlos syndrome is one of 13 subtypes that primarily affects the skin, joints, and blood vessel walls. 1 in 500,000 individuals have HEDS. The symptoms include overly flexible joints that can easily dislocate. This creates joint instability, leading to early onset osteoarthritis. Gait has been researched in adults with HEDS, but these results cannot be applied to children because of the size difference and their musculoskeletal systems have not fully developed. Using a software called Vigon Polygon, I created a Gait template in order to analyze gait cycles. This then led to the creation of a clinical report, which allows us to easily communicate our gait data with clinicians. The results from this study will be combined with genetic sequencing data to characterize the biomedical phenotype for HEDS, which will lead to improved diagnosis and treatment of therapeutic interventions to minimize pain and maximize function for children as they transition into adulthood. The first part of methods are the subjects. We have 7 subjects with HEDS, 3 are male and 4 are female, with a mean age of 14 years old. The data was collected with a 15-camera Vigon TS system, collecting at 120 Hz. The tasks include gait at self-selected, fast, and slow pace. Our data processing includes 5 gait cycles per subject, and the gait cycle divisions are identified by a heel strike and a toe off, allowing the walking trials to be broken up into cycles consisting of a stance and swing phase. These are the results for the temporal spatial parameters. I have included the speed of self-selected, fast, and slow, and the parameters being stride length, cadence, walking speed, stance, and swing phase. This is an average of 5 trials for 7 subjects. Kinematics was calculated on the hip, knee, and ankle in the flexion extension, abduction adduction, and rotation. Flexion is in the positive direction and extension in the negative direction. Adduction is in the positive, abduction is in the negative. Internal rotation is in the positive direction and external rotation is in the negative direction. This slide represents fast speed. The same follows for the self-selected speed kinematics, as well as the slow speed kinematics. Kinetics was also calculated at the hip, knee, and ankle. First, we have our fast forces, where 1 is the flexion extension, 2 is the abduction adduction, and 3 is the rotation. Same for the self-selected speed and the fast speed. The fast moments, we have the flexion extension moment, abduction adduction moment, and the rotation moment. As well for the self-selected speed moment and the slow speed moment. Our powers are present here, where we have hip, knee, and ankle powers, where power generated is in the positive direction and power absorbed is in the negative direction. This again follows true for the self-selected speed and the slow speed powers. An investigation into a larger population is ongoing to characterize the biomedical phenotype in children with HEDS. For the temporal spatial parameters, all individual subjects and the group averages fell within normal ranges for typically developing children of the same age. Additionally, trends for fast and slow pace follow. where fast pace leads to an increase in parameter output with a decrease in stance phase, while slow pace leads to decrease in parameter output with an increase in stance phase. In kinematics, when compared to healthy gait, the averages of children with HDS fell within normal ranges. However, inspection of individual subjects shows variance from typically developing children. Additionally, the trends follow for fast and slow pace, where fast pace leads to an increase in parameter output, while slow pace leads to a decrease in parameter output. For kinetics, when compared to healthy gait, the average moments and powers of children with HEDS fell within normal ranges. However, the average forces of children with HEDS varied from healthy gait. Inspection of individual subjects once again showed variance from typically developing youth. Additionally, trends for fast and slow pace follow, with fast pace leading to an increase in parameter output and slow pace leading to a decrease in parameter output, as we've seen for both temporal spatial parameters and kinematics as well. In conclusion, inspection of differences between those with HEDS and healthy individuals may provide insight into development of pain and injury over time. With this knowledge, clinicians and rehabilitation engineers may be able to work with HEDS patients to effectively decrease their risk of early onset arthritis. Overall, children with HEDS follow the expected trends for increased and decreased speed. This investigation is important for discovering potential fear of falling.